Ophthalmic complaints are seen in 96% of patients on presentation. Most of them have some level of optic atrophy, either as a result of initial compression, surgical resection, or radiation therapy. And finally, I'll be ending with psychogenic or functional loss of vision. I personally feel that functional loss of vision is a diagnosis of exclusion, and we need to do a detailed evaluation, a VEP and imaging before we commit to a diagnosis of functional loss of vision. If the visual symptoms are long-standing, if they are progressive, if they are non-fluctuating, then that essentially, over multiple visits, that essentially rules out a functional loss of vision, because children are not capable of keeping up the malingering on a sustained period of time. There are always, all our usual tests which we do, use a plano lens, chest for stereopsis, use red-green glasses. Those usually work in children, and if they aren't, there's usually an organic pathology happening. So I will end with this 13-year-old child who came complaining of multiple systemic complaints as well as ocular complaints. So there is headache, there's dizziness, there's blurring of vision, there's intermittent diplopia, there's stomach pain, there's joint pain, features of UTI, gait instability. Parents had visited every specialist possible, including and had every test done possible, including MRIs, lumbar punctures. Everything was completely normal. From an ocular point of view, the diagnosis was not difficult. The best corrected visual acuity was about 624. Patient had a bilateral abduction limitation binocularly. There was a esotropia, there was a variable pseudomyopia, which was with a lead of accommodation on dynamic retinoscopy, and near normal refraction on cycloplegic refraction. But what was interesting in this child was the multiple systemic features. This is her on the second or third visit, where she couldn't even walk, needed support even to take a few steps. Diagnosed her with spasm of the near reflex and started her on treatment with atropine and bifocals and reassurance, because she'd already been extensively investigated. Everything was normal. Parents, however, were unwilling to believe that. They went to a number of other specialists, went through a whole gamut of tests further. Child had IVMP, followed up with oral steroids, finally went to a psychologist, was started on antidepressants. It took a period of 18 months when the child was on atropine for the spasm to be relieved and for all the systemic features to kind of just disappear. I've had her on follow-up for 5 years now subsequently, and continues thriving, absolutely doing well at school, no subsequent relapses since then. So I would like to conclude by saying we can call it a functional vision loss only after ruling out all organic causes, and a repeated follow-up when the diagnosis is uncertain is required, because at some point we usually get a clue as to what is going on. Thank you. Sorry, फिर से खोल लीजिए. Dr. Jyoti, I'll just do Dr. SRB's presentation also, because it's on the same pen drive, and then we'll, yeah. नहीं यही वाला. खोल दीजिए. So, due to an emergency, Dr. Shikha Basi was supposed to be doing one of the... नहीं, वही खोल दीजिए, open कर दीजिए. यहीं पे, यहीं से open. Actually pick a binasal thinning. Yes. So in children, yes. You cannot do visual fields. If you're able to do that, like you did one for RNS, yes. At the same time, if you pick up the nasal thinning, which yes. corresponds to a bitemporal hemianopia, yeah. You can detect that there is a neurological decline. Definitely, yeah. So that's what, in this patient, I wasn't thinking in those terms at all. Just because of the pallor, just ordered an RNFL, I wasn't thinking in terms of craniopharyngioma, honestly, when ordering the imaging at all in this patient. Child was already dilated. So therefore I couldn't do, I've seen her on a single visit, pretty much. Dr. Shikha Basi is the Deputy Director of Neuro-Ophthalmology at Shankar Nethralaya, and she was supposed to be doing this talk on the mystery of the pale disc. However, due to a family emergency, she couldn't be here. So I'm just reading her presentation, and I'll try to do my best with it. So congenital disc anomalies may have an abnormal appearance pertaining to the size, shape, contour, or color of the optic disc. This may or may not have a visual impact, which may be abnormal, subnormal, or normal. And systemically, it may be associated with other congenital systemic abnormalities. So common congenital disc anomalies which we are used to seeing are the coloboma of the optic disc. This may be inherited sporadically or autosomal dominant inheritance. May be associated with the PAX2 gene mutations. The coloboma occupies the lower part of the optic nerve head, and the neuroretinal rim is absent inferiorly but usually identifiable superiorly, and vision may be impaired depending on the foveal involvement. So an OCT shows generally this deep excavation of the optic disc. And complications which may be present include peripapillary choroidal neovascularization as well as retinal detachment, especially in those also associated with an optic pit. Systemic associations, as we know, usually most commonly is the Charge syndrome, which includes the coloboma, choanal atresia, congenital heart disease, and multiple other abnormalities. Coming to the morning glory syndrome, this shows a conical excavation of the posterior fundus, including the optic disc, and is filled with glial tissue, and it's usually unilateral. So in this OCT, we can see that neurosensory detachment can be noted at and surrounding the disc and at the macula. Subretinal precipitates, ERM and ILM wrinkling and RPE alterations are noted. And subretinal moderate reflective echos and cystic spaces can be seen surrounding the disc. And here we can see the glial tissue, the tuft of glial tissue at the center. So ophthalmic findings which distinguish morning glory disc from optic disc coloboma include in morning glory disc anomalies, the optic disc lies within the excavation, whereas in optic disc coloboma, the excavation lies within the optic disc. In morning glory, usually there's a symmetrical defect where the disc lies centrally, whereas in an optic disc coloboma, there's an asymmetrical defect with the excavation lying inferiorly within the disc, and there's no central glial tuft. Severe peripapillary pigmentary disturbances can be present in a morning glory anomaly, whereas there are minimal disturbances in a coloboma. And the retinal vasculature usually has this spoke wheel pattern in a morning glory, whereas the vasculature is normal in case of a coloboma. Coming to optic nerve hypoplasia, this is one of the leading causes of blindness in children. There's an axonal loss due to apoptosis during development. Retinal and CNS ganglion cell failure may result from events occurring very early in the gestational life, which may include fetal alcohol syndrome and maternal diabetes. The blood vessel pattern can be normal. There can be this kind of tortuous blood vessel pattern, or they can be uncommonly straight. The uncommonly straight kind of pattern may be associated with the endocrine abnormalities, also commonly seen associated with optic nerve hypoplasias. The disc diameter to disc to macular ratio is quite enlarged in these patients, which is diagnostic. One of the common systemic features which are associated is septo-optic dysplasia or Demorzier syndrome, which includes optic nerve hypoplasia, pituitary gland hypoplasia, as well as midline abnormalities of the brain. And going with that, corpus callosum hypoplasia is the most prevalent neuroimaging abnormality which is associated with optic nerve hypoplasia. 84% of the cases are bilateral. Nystagmus develops within 3 months, which shows the early visual impairment followed by strabismus in the first year. Coming to optic nerve head drusen's, usually this kind of superficial drusen's are not visible in young children, but it's a common cause of pseudopapilledema in young children. When the drusen's are superficial, the disc may appear pale due to loss of RNFL. Children most often have buried drusen's, and these peripapillary ovoid mass lesions are more often associated with pseudopapilledema, as can be seen over here in children, rather than optic nerve head drusen, where the lesion is much more clear cut with superficial hyperreflective surface. Coming to Leber's hereditary optic atrophy, as we know, there's a maternal transmission of the disease. The peak age of onset is 15 to 30 years, and men are affected much more commonly than women, who are generally carriers. 3-point mutations in the mitochondrial DNA cause 90 to 95% of cases of LHON. They are located at the mitochondrial DNA positions 11778, 3460, and 14484, with 11778 being the most common and also having the worst prognosis for vision. This incomplete penetrance is seen in most of the patients, with only 50% of males and 10% of females harboring a pathogenic mitochondrial DNA mutation actually developing the optic neuropathy. And there is a maternal inheritance because it's a mitochondrial mutation. Females will transmit the pathogenic mutation to all their children, and males do not transfer the mutation. So in clinical presentation, asymptomatic LHON carriers may have telangiectatic vessels around the optic disc with central visual field defects. Symptomatic cases, generally there's a subacute onset, one eye followed by the other eye, characterized by painless loss of central vision. Vision usually ultimately 660 or worse, although over a period of months to years, there is a gradual improvement in some patients. The MR imaging is usually normal in the acute phase. Coming to autosomal dominant optic atrophy, it's generally a mild visual loss relatively. There's an insidious visual loss typically starting during the first decade of life, which generally tends to remain stable. It's believed to be the most common of the hereditary optic neuropathies. Usual onset is in the first decade of life, and the gene responsible most commonly is the OPA1 gene. And the product of the OPA1 gene is crucial for stabilization of the mitochondrial membrane integrity. Visual acuity is usually reduced to the same mild extent in both the eyes. It remains between 20/20 and 20/60 throughout life. And visual fields may show a central, paracentral, or secocentral scotomas. And the optic atrophy may be subtle or may just have a mild temporal pallor. Spontaneous recovery of vision does not happen. Coming to the Wolfram syndrome, or more commonly known as the Didmot syndrome. There's juvenile onset diabetes mellitus, diabetes insipidus, optic nerve atrophy, hearing loss, and neurodegeneration. The gene most responsible has been designated as the WFS1. Characterized by, as mentioned, diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. Most patients die prematurely with severe, in approximately the third decade, with severe neurological disabilities, most likely due to respiratory failure. And finally, autosomal recessive optic atrophy is characterized in early childhood. It's associated with variable pyramidal tract lesions, signs, ataxia, mental retardation, urinary incontinence, and pes cavus. And it's relatively rare. Visual loss usually manifests before the age of 10 years, is moderate to severe, and is frequently accompanied by nystagmus. Neuroimaging may demonstrate diffuse symmetric white matter abnormalities.